Assalamu alaikum. Good evening, everybody. Thank you for joining this webinar that's organized by Saudi Society of Men's Health and Sprout Education. I also would like to thank our sponsor, Tabuk Pharmaceutical. I'm pleased tonight to welcome our speaker, who is a very well-known sexual medicine specialist, Dr. Abdullah Al-Khayal. Dr. Abdullah is an assistant professor in King Saud bin Abdulaziz University for Health Science in Riyadh, and also he's a consultant urologist at King Abdulaziz Medical City in Riyadh. He will be giving his presentation tonight regarding erectile dysfunction for general practitioner. I just want to remind the audience that they can ask their questions in the Q&A section, and we will be happy to answer them at the end of the session. Without any further delay, Dr. Abdullah.
Thank you, Dr. Muhannad. I'd like also to thank the Saudi Society for Men's Health for their kind invitation. And I'll go ahead and start my presentation. I know, is the screen sharing working in a proper way?
Yes, it's clear.
Shukran. So today we're going to talk about erectile dysfunction for a general practitioner, which is a very common condition that probably all family physicians have been part of managing those patients. And this is a regular case that you guys see probably in your day-to-day basis. You have a 46-year-old who presents for a regular follow-up for his diabetes. He's known diabetic for the last 5 years on oral hypoglycemic drugs. He's also a smoker for the last 10 years. On examination, he has a body mass index of 28, so he's obese. Otherwise, all within normal limits. His laboratory tests are positive for a high fasting blood sugar and a relatively controlled hemoglobin A1C, in addition to an ultrasound that shows a fatty liver. In your routine practice, if we can just show the poll right now, in your routine practice, and with all honesty, how many of you will ask this patient actively about his erectile function? I will give this maybe 1 or 2 minutes just to see what is the practice of the people. So even if he didn't mention it, if he didn't say that he has an erectile dysfunction, how many of you will actively ask this patient about his erectile function? Good. So we have almost 36% will actively ask about his erectile function, while around 40% will not ask. They don't routinely ask about his erectile function, and hopefully after this lecture they will change their mind and will start asking about erectile function. So let's go back to our presentation. So how do we define erectile dysfunction? Erectile dysfunction is a multidimensional condition that involves any alteration of any of the components of the erectile response, including organic or relationship or psychological causes. Is it common? Yes, it's very common. In the West world, they did multiple studies that looked into the prevalence of erectile dysfunction, and probably the largest two are from the Massachusetts male aging study and the European male aging study, and both of them found that almost around 50% of those male between the age of 40 and 70 years, they will have some sort of an erectile dysfunction. So, and when we look at the diabetic men, we found that between 35 to 75% of diabetic men will have also erectile dysfunction. And when they are matched and they're compared to men who are non-diabetic, they found that they have their erectile dysfunction actually earlier by 5 to 10 years. So what about here in Saudi Arabia? Is it that common? 2 or 3 studies have been looking at this, especially in diabetic men, and they found that 60% of those less than 40 years who are diabetic will have some sort of erectile dysfunction. And another study have been looking at hypogonadism, and the range of hypogonadism in our society is between 18 to 22. So 1/5 of our society, of diabetic men in our society, will have some sort of hypogonadism. So why is it important to ask those patients about erectile dysfunction? In a meta-analysis that was done and published at the Journal of Sexual Medicine just last year, it shows that those, when comparing patients who have erectile dysfunction and those who doesn't have erectile dysfunction, they found that those who have erectile dysfunction have a higher chance of developing coronary heart disease. They will have a higher chance of developing a stroke, and they will have all-cause mortality that's higher than those who doesn't have erectile dysfunction. So it's very important independent risk factor to diagnose and treat accordingly, and try to modify as much as possible of the risk factors that's causing these more serious conditions. So what's the etiology of erectile dysfunction? As we said earlier, erectile dysfunction is not a one cause. It's a multidimensional. So most of the time, it's not only one disease that's causing erectile dysfunction, but it is a multi diseases that comes together. So patient will have a diabetes and he has depression, or he is taking antihypertensive drugs. All of these may act together to depress his erectile function. So, but in general, we classify erectile dysfunction into either a primary organic or primary psychogenic, or they can be mixed of a psychogenic and organic. If they are primary organic, which is the most common, especially in elderly men, it could be because of vascular, either iatrogenic causes or veno-occlusive causes. It could be because of hormonal, like late onset hypogonadism, or it could be because of neurological diseases that affect the erectile function, or it could be because of medication that like antidepressants or antihypertensive, or it could be primary psychogenic, as we see it more in in the younger population, or it could be mixed between psychogenic and organic causes. So how do we evaluate patients with erectile dysfunction? 4 important components should be included in any patient who presents with erectile dysfunction or who has erectile dysfunction, and we asked him actively about his erectile dysfunction. It should include history and physical examination. It should include laboratory testing, assessment of late onset hypogonadism, and cardiac risk stratification. I will go first by passing through the history and physical examination. I'm not going to give you a lecture about how to do a proper history, but in general, you need to ask about the patient about his general condition. And it's very important part is to ask him about his sexual history. Why is it important to ask about the sexual history? So we can grade his erectile function, we can assess, and we can treat it in a proper way. Asking about his sexual history will include his sexual orientation, previous and current sexual relationship, which is very important, especially in our community. Most of, not most, but some of our population are having multiple wives, they're planning to get married soon. So it's very important to ask about his previous and current sexual relationship, his current emotional status. The other important part is the sexual health status of his partner. Is his partner able to have the sexual intercourse and the sexual act with him or no? Detailed description of the rigidity of the penis is very important. And as well as the duration of both the sexually stimulated and self-stimulated erection. We see a lot of patients that comes to us and they're complaining of erectile dysfunction, and basically they will say, I have a good erection with my masturbation, while when I go for my wife for my sexual intercourse, I don't have as good as when I do it by masturbation. The fourth point is the questionnaires. Sometimes using questionnaire, especially in a very busy clinic, it's time consuming and not all people will use it. However, it's very important to know what's in the questionnaire so we can ask them in the proper way so we can grade the degree of their erectile dysfunction. The last component to ask is about the symptoms of late onset hypogonadism or hypogonadism in general, which may include decrease in their energy, libido, fatigability, and cognitive impairment, as well as the urinary tract symptoms. So the questionnaire that's most commonly used is the International Index for Erectile Function. There's a shorter version, which is called the IAF-5, that concern more with the erectile power, and that can grade our patient into severe, moderate, or mild erectile dysfunction, or they have no erectile dysfunction. The other instruments that can be used, and it is very helpful, especially in clinical practice, because it helps for the patient to give you an idea about his erectile status, is the erection hardness score, which can be scored from 1 to 4, and it's easy to help for the patient to understand it. Like when you ask him about his full erection, if he tells you that it's like a sponge or like a tofu, then you will put it as 1. If the patient is telling you that his erectile function is hard enough, like a cucumber, then you will give him a grade of 4. That will give you a better idea about his erectile function and erectile dysfunction. The second point is the physical examination. So the physical examination for those patients should include general examination of the patient, including genital examination and prostate examination. It is very important also to look for symptoms, for signs of hypogonadism, like gynecomastia and central obesity and BMI calculation. That will help for the management as well. Then we go to the second component of evaluating those patients, which will include the laboratory investigation. So what are the recommended laboratory investigations for all patients who present with erectile dysfunction? Is basically a CBC and blood chemistry, fasting blood glucose for those who are not diabetic, and a hemoglobin A1C for those who are diabetic, plus a lipid profile and early morning testosterone. I will come to the rationale. Why do we ask for these tests, especially for patients with erectile dysfunction? Additional tests which should be included if you think it's indicated. That will include a prostate-specific antigen if the patient is at the age of PSA screening and prostate cancer screening, prolactin if the patient is having symptoms or signs of hyperprolactinemia, LH if the patient is having hypogonadism and you want to rule out if the patient is having hypogonadotrophic hypogonadism, and whatever routine investigation that is needed to help you to reach a diagnosis that can be also asked for. But in general, the mandatory test is a CBC, blood chemistry, fasting blood glucose, hemoglobin A1C, lipid profile, and early morning testosterone. So here is the algorithm that's suggested by the American Association of Urology in 2019's guidelines, is to go for history to identify the other sexual problems other than erectile dysfunction, including premature ejaculation, orgasmic problems, identify the common causes of erectile dysfunction, to identify the reversible causes of erectile dysfunction, and to assess the psychological status of the patient. Do a focused examination that will include to look for any penile deformities or penile plaques, prostate diseases, signs of hypogonadism, and cardiovascular and neurological status, in addition to the laboratory tests that we talked about. So why do we need to assess for patients with late onset hypogonadism? It is known that declining in the androgen level associated with the components of metabolic syndromes. In obesity patients, there is an inverse correlation between the plasma testosterone levels and the BMI, waist circumference, and the waist-hip ratio, and the amount of visceral fat. In patients with dyslipidemia, it has a positive correlation between the plasma T levels and the HDL. And there is an inverse correlation between the triglyceride, total cholesterol, and the LDL. In patients with hypertension, there is an inverse correlation between the testosterone level and the systolic blood pressure, as well as the diastolic blood pressure. In patients with impaired glucose tolerance and diabetic patients, there is a low testosterone is also associated with insulin-resistant diabetic men would usually have a lower T level. So what do we need to do to diagnose late onset hypogonadism in males is to obtain a serum sample of a testosterone that's early morning, between 7 o'clock and 11 o'clock in the morning. If the level is less than 8 nanomoles, then those patients will usually benefit from testosterone replacement therapy. If it's in the gray zone between 8 and 12, then it's better to repeat the total testosterone and get the sex hormone binding globulin to calculate for the free testosterone. And if it's more than 12, they usually don't benefit from testosterone replacement therapy. The fourth component is the cardiac risk stratification. The Princeton consensus have divided the cardiac patient into a low risk, intermediate risk, and a high risk. Why is it important to know these risk groups? Is basically because erectile dysfunction and cardiovascular disease, they share the same pathophysiology. Patients with coronary artery disease and coronary vascular diseases, risk factors are the same as for patients who have erectile dysfunction. And in 30% of the cases, coronary vascular disease may manifest initially as erectile dysfunction. So it's very important to assess their cardiac ability because once you assess their cardiac ability, that you will know their exercise ability, because we hear a lot of the times that the patient took a PDE5 inhibitor, they went to the emergency, they had a heart attack. Some of the people, especially the population, they refer this to the PDE5 inhibitors, while the most common thing is their exercise ability. Sexual activity is almost equivalent to climbing 2 flights of stairs in 10 seconds. So if the patient is able to perform all of this exercise, then they're able to perform sexual intercourse, and they are categorized as a low risk. If the patient is not able to perform this exercise activity, then they should be graded as a low risk, as an intermediate risk, or a high risk. So if you know how to classify your patient's cardiac status, you will be better able to manage this patient and give him the proper medication. So the indication, is there any indication for any specific diagnostic test? 90% of the cases, this is what you need. Is basically history, physical examination, evaluation, laboratory test, evaluation for late onset hypogonadism, and risks and cardiac risk stratification. There is some minority patients, around 10% of the erectile dysfunction patients, who will need specific and extra tests. Who are those patients? Are young patients with history of pelvic or perineal trauma that may benefit from revascularization surgery, patients with penile deformities that may need surgery to correct the penile deformity, or patients with complex psychiatric or psychosexual disorders that will need an evaluation by a psychiatrist, patients who have complex endocrine disorders like patients with hyperprolactinemia or hypogonadotropic hypogonadism. They will need a replacement of other hormones, or some patients will ask or request for these tests, which they may not need it. Or the other reason is a medical legal reasons. Sometimes you will receive, or we receive a court order to evaluate a patient because of قضايا خلع أو أيا كان, or before planning a patient for penile prosthesis, or in cases of sexual abuse. So how do we manage patients with erectile dysfunction? So it's very important to identify any curable causes of erectile dysfunction and correct them. So if the patient is poorly controlled diabetic or hypertensive or hypercholesterolemic or has obstructive urinary symptoms or coronary vascular diseases, evaluate for his medication, especially antihypertensive and antidepressant, which causes erectile dysfunction, then this will help in your management. It's very important to tell the patient and make it clear from the first visit when the patient presents for erectile dysfunction that erectile dysfunction can be treated successfully, but it can't be cured. So we have a lot of patients that have very high expectation that after I got 4 or 5 doses of PDE5 inhibitor, I can go back to be an 18-year-old boy. It's very important to explain to those patients that this is not possible. So we are here to help you, but not to cure you. So we can treat it successfully, but we can't cure it. The only exception, of course, is psychogenic ED patient, post-traumatic or arteriogenic ED patients, or those who have hormonal problems. So the most common modifiable risk factors that we should look for is the lifestyle. If the patient is having a sedentary lifestyle, increasing the physical activity, especially weightlifting, it helps in gaining his erectile function back. If the patient is having depression, then treat this depression. Some of the patients will regain their erectile function. If the patient is having a poor control diabetic, then improve their control, their diabetic control. If patients in alcohol or is using tobacco, then help them by with quitting their alcohol and tobacco. If the patient is having hypogonadism, then initiating testosterone replacement therapy will be helpful. If patient is is overweight or obese, weight loss will help some of those patients. So if the modifiable risk factors are controlled, then we go for the oral medication. So oral pharmacotherapy will include a PDE5 inhibitor. We have here in Saudi 3 types of PDE5 inhibitors: sildenafil, tadalafil, and vardenafil. And it's very important when you give these medication to the patient that they understand that PDE5 inhibitor is not an initiator of erection. Patient will still need to have a sexual stimulation. We have some patients that will take their medication and they go sit and watching TV waiting for the erection to happen. It will never happen. They will need to have a sexual stimulation for this medication to work. So what's the difference between those 3 medications? In terms of efficacy, all of them will share the same efficacy. However, there is in their pharmacotherapy, in their pharmacokinetics, there's some, and their side effects profile, there's some differences. For example, tadalafil is not affected by the food. So it's in relation to the food, patient can take it even if he just had his meal, while sildenafil and vardenafil, they usually have a reduced absorption after a fatty food. So we advise the patient to have it after 2 hours of a meal, at least 2 hours after a meal, and not to be a heavy meal. In terms of dosages, they are available in multiple dosages. Their side effects profile is almost similar. The most common is headache and facial congestion and blurred vision. Tadalafil will have more of back pain and myalgia in general. They are all contraindicated in patients who are taking nitrate. They may have severe hypotension. So before prescribing this medication, you need to make sure that the patient is not taking nitrate. As we've seen many cases that comes to the emergency room with an MI because of the use of PDE5 inhibitor, and after sexual activity, they will have an angina, they go and take their nitrate, and then they collapse. One note about tadalafil specifically, that tadalafil 5 milligrams has been approved by the Saudi FDA and the American FDA for the use for both erectile dysfunction and PPH. It's given as a 5 milligram daily dose. It is actually my preferred medication for any patient who present with lower urinary tract symptoms and erectile dysfunction. Instead of giving him an alpha blocker with PDE5 inhibitors, I prefer to give them first the PDE5 inhibitors, see their effect in both the PPH and the ED, and see how's the response. And based on that, I can add or subtract any medication. So in terms of their safety issue, all the PDE5 inhibitors are not, doesn't increase any the myocardial infarction rate. If they are co-administrated with any hypertensive, it's considered safe. If a PDE5 inhibitor is given with an alpha blocker, it may cause orthostatic hypotension. It is considered, as I said, contraindicated in any patient who's taking nitrate, or a patient on a high risk group for their cardiac risk group is high. Then it's also contraindicated, not because of the medication itself, but because of the sexual activity, which may subsequently cause a heart attack or a problem for them. So how do we manage patients who are non-responders? First of all, we need to make sure that those patients took the adequate sexual stimulation. This is very important, as I mentioned earlier. We need to make sure that the patient took an adequate dose of their medication. Some of the patients, you will give them a full dose of any of the medication, but they are afraid and they prefer to cut, the medication or crash it and take half of a tablet, and they will tell you it's not working. Failure to wait for an adequate amount of time. So we advise the patient to take it 1 hour or 2 hours before sexual intercourse. And as I said, with the sildenafil and verdanafil, to make it after 2 hours of a meal. So the other first option include the vacuum erection device. This is a good choice for patients who are high risk for surgery or non-responders to PDE5 inhibitors, or patients who prefer a drug-free management. So basically, they put it around the penis, they pump it will gush the blood into the penis. There is a ring that will be placed at the base of the penis that will hold the blood in the penis. The satisfaction rate with this management option is very high, and the adverse effect is very low. It includes pain, patients unable to ejaculate, petechia and poozing, and sometimes numbness. It's very important to advise the patient not to keep the ring for more than 30 minutes to prevent any skin necrosis. The other treatment option include the extracorporeal shockwave therapy. You hear it in all the social media, and there is a lot of social media advertisement about many clinics that has the shockwave therapy. Till now, we can't have a conclusion or recommend this as a first line. It is an option, it is there. However, the efficacy is still questionable, and we still need more studies and more long-term studies to define the role of extracorporeal shockwave therapy as a management option for patients with erectile dysfunction. So if all the medication fails, or the first line options fail, then the second line option. I always tell the patients that managing a patient with erectile dysfunction is like climbing a ladder. So you need to go step by step. We can't go from one to the other. Some of the patients will come asking for surgery or asking for injections. So it's very important before we go to a second line is to explain to them the way we're managing. It's like climbing a ladder. We need to go a step by step. So the second line is intracavernosal injection, which will include intracavernosal alprostadil. They usually inject it on the side of the penis that 5 or 15 minutes before sexual intercourse. The satisfaction rate for both the patient and his partner is very high. However, there is 10% of the patient that may take an extra dose. So if starting a patient on alprostadil, we should start from the lower dose till the higher dose, just to prevent the patient from having priapism. It's very important to advise them that if they have an erection that lasts more than 3 hours, to come immediately to the emergency room to treat their priapism to prevent further fibrosis and further problems that they may have. So if the first line management fails and the second line management fails, then we go to the third line, which is surgery. Surgery, the only option for them is to have a penile prosthesis. We have two types of penile prosthesis. We have the semi-rigid or the malleable penile prosthesis, and we have the inflatable penile prosthesis. Both of them are considered safe in good hands. However, patients need to understand that this is a one-way ticket. So there's no going back to injections. There's no going back to medication if they had a penile prosthesis. Penile prosthesis is considered a safe surgery, but it has some serious side effects that, with better counseling with the patient and better understanding with the patient and better explanation, all of this can be avoided. And over here, I'll give you just a full summary of the management option. So the only first line medication that has a strong evidence is PDE5 inhibitors. In addition to treating the underlying causes and lifestyle modification, the second line is the intracavernosal injection, and the third line is penile prosthesis. And by this, I conclude my presentation. Thank you very much for listening. And thank you very much for the Saudi Society of Men's Health for their invitation. Here is my contact. If you have any questions or any comments, you can just send me by email or my cell phone. And please let me take this opportunity to ask you all to join us in our campaign raising the awareness of men's health. You can follow us on the Men's Health public account on Twitter and help us to raise the awareness of men's health in this month of November. Thank you very much.
Thank you, Dr. Abdullah. Excellent talk as usual. It was a very informative and enlightening presentation. We have a few questions here. The first one is regarding the approach to patients who is less than 40 years old, presenting to the clinic with erectile dysfunction. Would you treat them differently?
It depends on his medical condition. So if the patient is having a medical condition, I will not treat any patient differently unless I think it's a psychogenic erectile dysfunction. So the main way is to differentiate between primary psychogenic erectile dysfunction and primary organic erectile dysfunction. So if you think that the patient is having more of an organic, if he's less than 40 years, but he's diabetic type 1, I would consider this as a primary erectile dysfunction, primary organic erectile dysfunction, and I will treat him as an organic erectile dysfunction. If they think the patient is having a psychogenic erectile dysfunction, and the only way to differentiate between them is to take a proper history. So if you're taking a proper history from the patient, you will be able easily to differentiate between primary organic erectile dysfunction and psychogenic erectile dysfunction.
Okay. There are many products, that's another question. There are many products in the markets available that's either herbs or antioxidant like L-arginine, ginseng, and yohambine. What do you think of that? Shall we prescribe it for the patients?
Well, there is no real data or no real randomized control trial that recommended these medications or these herbs or supplements. However, some patients will ask for it, and some of them will go to the pharmacy and just ask for it. Would I recommend to give it to the patient? I usually don't give it to the patient unless they ask for it. They ask for a herbal medication that may help them. I will give it to them with explaining to the patient that it may not help.
Okay. Another question, what do you think about stem cell therapy and also plasma injections? Do you
Well,
think
there is a lot of advertisement, like for the shockwave therapy, for stem cell therapy and PRP. However, still, we don't have a conclusive evidence that it helps with erectile dysfunction to make it as part of the guidelines or part of the management options for those patients.
Okay. So for general practitioner, when do you think they need to refer the patient to a urologist or a sexual medicine specialist? Is there any scenarios where they need to refer the patient to the urologist?
Well, I think patients who they think that will benefit from a more expert consultation, I think this patient need to be referred. If the patients are becoming PD5 non-responders, then it's better to be referred. If the patient is more of a complex, like trauma patient that may benefit from revascularization, then yes, they need to be referred. So this is what I think of in terms of which patients need to be referred. Most of the patients who need to be referred are those who are not PD5, who are PD5 non-responders.
Okay. And also there is another question. Upon prescribing PDE5 inhibitors, is there any specific instructions that the general practitioner need to give to the patient to make sure that the PDE5 inhibitors will be effective?
Yeah, so it depends on which PDE5 inhibitor you're using. But in general, if the patient is given sildenafil or vardenafil, it's better not to be taken after a fatty meal. That will decrease their absorption. In terms of dosages, usually it depends on which medication, but usually with the degree of the erectile dysfunction, you can judge either to give him a full dose or a half dose. So for patients who are having a very mild erectile dysfunction, then maybe the lowest dose is possible for them. If the patient is having a more severe form of erectile dysfunction, then the higher dose should be started first. So and the advice for the patient is, if you're taking a PDE5 inhibitor, you need to have a sexual stimulation. Lots of patients who take PDE5 inhibitors, they take it and wait for the erection to happen. It's very important to mention this to the patient that that PDE5 inhibitor is not an initiator of erection. It's just a stimulation and help you with after the sexual stimulation.
Okay. Some patients, they ask, is there any difference between the various PDE5 inhibitors in terms of effectiveness?
In terms of effectiveness, there is no study that looked and compared PDE5 inhibitors against each other. So we will say that this is more effective or that's more effective. The study that had these drugs approved are against placebo, and all of them showed the same success rate. So unless there is a study that compared two PDE5 inhibitors, there is no single PDE5 inhibitor is more superior to the other. The only thing is the difference in the side effects profile. So if a patient is having more headache with one medication, you can switch him to another medication that will cause less headache. If the patient is having more of muscular pain and back pain with one medication, you may switch him to another medication that will cause less muscle pain and back pain.
Thank you. So for general practitioner, is there any a specific indication for referring the patient for Doppler study for the penis?
Yeah, for Doppler, I mentioned it in one of the slides that in patients who you think a further study may be needed, then a Doppler will be indicated, especially in those who have a penile deformity. A Doppler will be helpful. If you're in doubt about the cause of the erectile dysfunction, like in a patient with a venous leak, you will think that a penile Doppler will help you more. You're not sure, especially young patients. Is it a venous leak or a psychogenic erectile dysfunction? Then a Doppler will be beneficial.
Okay, excellent. So another question here is regarding penile prosthesis. So for general practitioner, when discussing with the patient, if the patient asks him about penile prosthesis complications, what are the most important ones?
Sorry, I didn't get your question.
Regarding complications of penile prosthesis.
Yes.
For general practitioner having a patient in the clinic, asking him about possible complications.
So the possible complication, the most important, and this is what we tell the patients as the most important and frightening for us as implanters, is basically infection. Because if infection happens, the penile prosthesis need to be removed to treat that infection. It can't be treated while the prosthesis is there. If a patient is planning for an inflatable penile prosthesis, there is a chance of mechanical failure. Although it's low, patient needs to know about this. Erosion and exclusion from the penis, it is also low, but the patient needs to know about this. Other things like penile shortening and more of observatory complication, that will also be need to be explained to the patient. But if you're going to ask me what is the most important, I will say infection is the most important.
Okay, excellent. So there is another question here regarding psychogenic ED. Is there any specific questions in the history or elements in the physical examination or investigation that can really rule out psychogenic ED?
Yeah, so for psychogenic ED, if you ask me, I will tell you history is the most important thing. So if you ask a patient in a very detailed history, you will be able to diagnose psychogenic ED. Other tests, which I don't think that it is actually available in any of the centers, is to do the night erection and Thomason's test, but I'm not really sure if it's available in any of the centers here in Saudi.
Okay, so there is another question here regarding what's the best medicine used to reduce myalgia side effect of PDE5 inhibitors?
Non-steroidal anti-inflammatory.
Okay. And among the PDE5 inhibitor, is there anyone that has the least effect of myalgia?
In terms of myalgia?
Yes.
Usually vardenafil and sildenafil will have a less effect on muscle pain and back pain.
Okay. There is another question regarding the indication for penile prosthesis. For a patient coming to a general practitioner clinic, is there any specific indication for penile prosthesis?
So in general, the penile prosthesis is not it's not an indicated. Erectile dysfunction is not a cancer. So it's a patient wish and patient preference. So if a patient is failing or oral and injection therapy, then a penile prosthesis is considered an option. We never force a patient to have a penile prosthesis, but if the patient wish to pursue a penile prosthesis, then yes, it is a third line option.
Excellent. Is there any, that's another question, is there any risk of having priapism with PDE5 inhibitors?
It is there on the safety instructions from the companies. However, I'm not aware of any reported cases of priapism secondary to a PDE5 inhibitors.
Okay. That's another question regarding any specific instruction regarding PDE5 usage for chronic kidney or chronic liver disease.
For chronic liver diseases?
Yes.
I'm not really sure, but I think it's safe. It's
Okay.
it's not considered indication, contraindication.
Okay. There is another question also regarding PDE5 inhibitor abuse in healthy people.
Yeah.
Like healthy patient without any erectile dysfunction. Do you think there is an effect of abusing PDE5 inhibitors?
I mean, is there an abuse? Are they? Is there people who are who doesn't have erectile dysfunction and use PDE5 inhibitors? Yes, definitely there is. Is there an effect of PDE5 inhibitor in those patients? It's usually no. PDE5 inhibitor is not addictive. However, those patients will have more of a psychological dependence on PDE5 inhibitor. So if they take a PDE5 inhibitor, they will think that their erection will never be good unless they take a PDE5 inhibitor.
You know, there is another question regarding PBH. Patient with PBH on alpha blocker, is it okay to prescribe PDE5 inhibitors? Is there any precaution?
Sorry?
Is there any precaution for patient taking alpha blocker for PPH and you want to prescribe them PDE5 inhibitors? Is there any precaution?
Yeah, the only thing that they may have an orthostatic hypotension. So if patient is on PDE5 inhibitors and he's taking PDE5 inhibitor, there is a higher risk of having an orthostatic hypotension.
Okay, thank you. There is another question regarding, is there any association between varicocele and erectile dysfunction?
Varicocele and erectile dysfunction?
Yes. Is there any association?
So varicocele by itself may cause hypogonadism. So if a direct association between varicocele and erectile dysfunction, no, there is no. But in a different way is that varicocele may cause late onset hypogonadism, and this hypogonadism may affect the erectile function.
Okay. There is another question regarding using of hormonal treatment like clomiphene citrate or tamoxifen as an empirical therapy for patient with erectile dysfunction. Is there any role?
If the patient doesn't have hypogonadism, then there is no point of using it as a treatment of erectile dysfunction. So if the patient's testosterone level is normal, clomiphene citrate, I don't think that it will be helpful for those patients. I don't use it, but I don't think that it will be helpful.
Okay. There is another question regarding total testosterone. Why we do it in the early morning? Is there any specific reason?
Yes. So why we do it in the early morning is to follow the circadian rhythm of the testosterone secretion. So usually the testosterone secretion is higher in the early morning, and then it slows down over the day. So we take it at the maximum levels of testosterone, which is the early morning between 7 o'clock and 11 o'clock.
Okay. There is another question regarding tolerance of long-standing usage of PDE5 inhibitors.
So does the patient form a tolerance?
Exactly, yeah.
Yeah, this is a question of a debate. Is it a tolerance or this is the progress of the disease? Okay, PDE5 inhibitor will never cure erectile dysfunction, but their atherosclerosis and decreasing in the blood supply that goes to the penis will be diminishing with time. So do we give PDE5 inhibitor to try to prevent this? It's still debatable. We don't have an answer for this. And do they form a tolerance? Again, it's a question of a debate. Is it tolerance or this is the progress of the disease?
Thank you, Dr. Abdullah. There is another question regarding the role of free testosterone. Is total testosterone is enough, or we need to do the free testosterone?
Yeah, so according to the guidelines, that a free testosterone is not indicated in all patients. Free testosterone need to be checked only in patients who have a total testosterone that's in the gray zone, which is between 10 and 12. Between 8 and 12. So if the total testosterone is between 8 and 12, then a free testosterone is indicated in those patients. But in general, depends on the free testosterone. Measuring free testosterone is a little bit expensive. It's not easy. So you need to have these sex hormone binding globulins to subtract it from the total testosterone so you can have the results of a free testosterone. So do we need to do this for all patients? No, total testosterone will be enough. Unless it's in the gray zone, then a free testosterone will be indicated.
So that leads me to another question. Is there any role of doing prolactin, FSH, LH, estradiol? Is there any specific indication for doing these tests in patients with erectile dysfunction?
For all patients, no. However, and there is a specific, according to the guidelines, there is, not for all patients you will do these unless there is a specific indication. Like I do an estradiol ratio in patients who are morbidly obese, just their testosterone is in the gray zone. Then I will ask for further tests. If a patient is having symptoms of hyperprolactinemia, I may ask for a prolactin, but not for all patients.
Okay, thank you. There is another question regarding for total testosterone, when you ask the patient to do it in the morning, does he need to be fasting or
no?
It doesn't need to.
He doesn't need to be fasting.
Okay. But
it's a good practice. It's just 1 minute. It's a good practice because you're asking a patient to do a lipid profile and and fasting blood glucose, and those usually will require fasting. So it's a good practice to ask for the testosterone with these investigations, where the patient will come in the early morning and he will do them all together.
I agree. There is another question regarding patient with diabetes. If they control their blood sugar, can their erectile dysfunction be cured?
Yeah, again, once erectile dysfunction starts, it will be very difficult to cure it. It may improve it, but it will never be able to cure it. I won't be able, I always tell the patient that I'm not able to bring you back to your 18s. I'm not be able to bring you back to your 20s. But if we work on this and that, you may benefit from it, and you will not need the medications right now. And you may stay longer without the need of medication. So again, curable diseases for anorganic causes is very difficult, and especially if the cause is diabetes or hypertension or dyslipidemia. But we will always give the patient the plan from the beginning.
There is a question regarding PDE5 inhibitors. Do you escalate the dose, like in sildenafil, Viagra, or Cialis? Do you ask the patient to start at a low dose, then increase it, or they can start with the maximum dose?
Yeah, in general, there is no recommendation about starting a lower dose or starting a higher dose. But what I usually do is to try to prevent the side effects profile of the medication. With a lower dose, they will have a less side effects profile. There's some patient who takes tadalafil 20 milligrams and they're not able to tolerate it because of the side effects. And once they take the 5 milligrams, they're able to tolerate it with the less side effects. So if the patient's erectile function is very mild, I usually start with a very low dose. If the patient's erectile dysfunction is in the moderate or severe, no, I start with the full dose immediately.
Okay, thank you. Is there any role of vitamin E in erectile dysfunction?
There is no conclusive evidence about that. The vitamin E is one of the antioxidant. The antioxidant roles in erectile dysfunction is very it's not well studied, and there is no enough conclusions that can be withdrawn from the study that have been done on that.
There is another question regarding the relationship between erectile dysfunction and chronic prostatitis. Is there any relationship?
Yeah, so there is the theories about erectile dysfunction and their association with chronic prostatitis. We see a lot of patients with chronic prostatitis and erectile dysfunction. Is the cause is their chronic prostatitis? There is a theories about that, especially about their neurological or their change on the hormonal regulation. But in general, there is no direct relationship between chronic prostatitis and erectile dysfunction.
Okay, excellent. There is another question regarding some patients to prolong their erection time, they use topical anesthesia or duvoxetine, but they complain about weakness of erection. Is there any relation between them?
Between
them.
Between you mean the local anesthetic and the erectile function?
Yes, and the two and the duvoxetine too. Yeah.
Yeah. So again, now we're talking about premature ejaculation. So patients who have premature ejaculation and they use local anesthetic, it's all about how would they use it, because the penis, if the penis doesn't have enough stimulation in terms of friction, they may lose their erection. So it's very important to instruct them how to use the local anesthetic. Is not to put it in the whole penis, just keep it on the tip and keep it for 10 minutes and then clean it up, not to have a fully anesthetized penis.
Excellent. Okay, there is one more question. I think we have time for 2 more questions, then we will conclude. So this question is asking about what are the maximum days to be used in the week for PDE5 inhibitors? Is there a limit?
For PDE5 inhibitors?
Yes.
PRN, you mean?
Yeah, is there a limit?
PDE5 inhibitors?
Yes, PRN.
Yeah, there is no limit. He can use it on a daily basis if he's healthy enough.
Okay, I think that's it. Thank you so much, Dr. Abdullah. This concludes our session. Really appreciated. It was a very informative and a comprehensive presentation.
Thank you very much. I just want to say one word to the participants. Thank you very much for attending. Thank you very much for staying till the end. And we really appreciate your support, the Saudi Society of Men's Health. If you can help us with our public awareness campaign to be part of raising the awareness of men's health. And thank you very much.
Thank you, Dr. Abdullah. I also would like to thank Prof. Saleh bin Saleh, Dr. Raid Al-Mani, Saudi Society of Men's Health, Sprout, and our sponsor, Tabuk Pharmaceuticals. Also, I echoed what you said, Dr. Abdullah. I really thank the audience for staying till this time. Thank you so much.
Thank you, Dr. Muhannad, and thank you, Dr. Abdullah. Very well moderated and delivered. And hopefully, inshallah, we'll have another meeting like this in the near future. Thank you again.